Basically, this is a review of the literature that we have to understand with the present idea that the cervical TDR or cervical arthroplasty is about 2 decades old plus. We were all very enthusiastic when we started as a corollary to what the questions that were asked by our chairman. Well, I have had experience of doing 1 level, 2 level, 3 levels. I didn't do 4, but the number of 3 levels were some 5 or 6. And hopefully they are doing well. That was because of the initial enthusiasm that we had, and was thinking that that would be the panacea for all the evils that we thought would be due to the loss of understanding or less understanding of our sagittal balance in those days. As we gain knowledge about sagittal balance and the whole body spine, understanding it better, the amount of cervical disc replacement has gradually gotten worse. Actually, we don't do so many replacements as we did, say, in the early part of between, say, 2010 and 2015, just as a history. Again, I thank the organizers for this. So I'll just skip the initial thing. What I wanted to understand was, for those people who are young, may not have done the grafting. We used to do grafting from the iliac crest for a long time, and that was gold standard for us. And very rarely we used to have pseudoarthrosis. But as you see, if any number of case reports and the series reports, the pseudoarthrosis malunion at 1 year became a well-documented complication in ACDF. So to improve the fusion rate, we started using a lot of enzymes and other things, including plating. So why should we, if we have a good fusion, which is fabulous, why should we have alternative procedures like TDR? Basically because with multi-level fusion, you start a progressive loss of global motion, and we wanted to see whether TDR will help preserve motion and also help reducing the adjacent segment degeneration. Therefore, there are a lot of studies to say biomechanical analysis with what happens at 1-level fusion, what happens in 2-level fusions, etc., etc. And we realized that in those days when sagittal balance, as I told, was not fully understood, it was all regional motion that was being discussed. So the idea of CDR, greatly as an interest, became very, very interesting. So this is an old picture which I could get from the Funstorm ball. So the actual CDR started with this, what you call as the Frenchay device, which was in 2002. So then it has undergone several modifications, and then it slowly became a standard of care in many centers. And the initial thought process was it preserved the range of motion. The overall cervical alignment was maintained, and the first 1 or 2 years of study showed that the range of motion was preserved. There was a lot of excitement at the time. And Mumanene in 2007 actually did a 2-year follow-up of a large number of patients, 276 patients undergoing arthroplasty, and about 265 patients control one ACDF. This is one of the largest series I've seen in the literature. And they said there was no implant migration. There was actually, the NDI was better. There was clinical outcomes was better, and the lower rate of secondary surgeries, saying that TDR would be a wonderful way to prevent in long term. And actually during the early part of the 2010 to 2015, the number of surgeries for cervical arthroplasty became gradually so big, and we thought that would be the future. There was 5,000 ACDF to 1 cervical disc arthroplasty in 2005. By 2007, it became 100 to 1. So indicating the huge number of cervical arthroplasty. And as people started realizing by 2009, something is not right, we started getting more and more results. All of them indicating there is some benefit, but not an overall great benefit. Then we wanted to see what happens in whether it was any design that caused any difference, like a constrained, semi-constrained, or fully constrained. So we had a lot of papers on all these things. Basically, all of them gave a very marginal degree of improvement or a worsening, whether it is constrained, semi-constrained, except for a minutiae in differences. All of them were actually very similar. So by 2013, the arthroplasty usage had reached its peak, and everybody was thinking that it is one of the best things to happen for cervical disease. We also joined the bandwagon. We started using this, what we call as Prestige low profile. The earlier Prestige had screws, it was constrained. This was not a constrained device. And by 2014, a large series of patients were already in the literature in this, with experiencing for 5 to 7 years, and we are looking for 10-year outcomes now. At the end of 10 years, the outcome that came out was that the adjacent segment degeneration reduced by about 20%, but the range of motion that was preserved at 5 years was not seen at the range of 10 years. So there are a lot of studies. I just want to go through it fast because of lack of time. Basically, whatever may be the design, every 10-year study said that neck improvement was better, the range of movement was better, and the adjacent segment was better. But I'm not sure whether this is to be understood, because actually there is no statistical difference. If you look at and you spend hours looking at the statistics, the marginal range, 3%, 5%. So it lets me to believe, is it really worth doing all this for a 3%, 5% improvement? So let me go to the latest 2024 study. I just skipped it because the range of movement, center of rotation was discussed by the previous speaker. This is the latest paper, relative efficacy of cervical TDR and fusion. Now what happens is there were 6 studies comparing all the devices that are available in the market, and then as usual, there was a quantitative comparison of the range of movement, patient success, complications, etc. So all the literature showed that it was marginally better than ACDF. So the so-called superior outcomes I see is in the range of between 5 and 15%. When you are looking at all these studies being supported by companies, I somehow wonder this 5 to 15% is really worth it. So in conclusion, I would like to say that the cervical total disc arthroplasty has proven to be an efficacious treatment, with an option and a caveat saying that it is to be judiciously used. The adjacent segment degeneration that is supposed to be said is in the range of 15 to 20%, and effectiveness is definitely based on both patient and device specific factors. Thank you so much.
Thank you very much, Dr. Rajkumar.